All right. And we are live. It was already recording. Yeah. All right. A little blooper for those who are live with us. All right. Now we're recording again. So if you're joining us live, welcome. This is the Med Matrix Method podcast. We're going to be talking about two really exciting subjects today, hormones and vitamins, specifically how to optimize them. What does it mean to be deficient in some of these things? What are the strategies you can do in your day-to-day life? What are things that you can do with cutting-edge medicine, working with a practice like Med Matrix? None of what we say is medical advice. This is for educational purposes only. And if you're interested in working with MedMatrix as a patient, you can go on over to medmatrixusa.com and click get started. All right. So first, we're going to kick things off by talking about vitamin deficiencies. So Dr. Rose, welcome. Thank you for making time after a busy day. Appreciate
You're
it.
welcome. Happy to be here.
Yeah, if you can't tell, if you're just listening on audio, Dr. Rose and I are matching. We're wearing the same sweater. Yeah, we got some new merch. We love merch. So yeah, all right, guys. So, Dr. Rose, why don't you talk a little bit about vitamin deficiencies? What are vitamin deficiencies like actually?
Well, vitamin deficiencies are when, for a variety of reasons, an individual is not getting sufficient or optimal levels to help with the body's normal metabolic pathways, hormonal pathways. So kind of like, I think of it as like working with a handicap, and usually people don't know that they have vitamin deficiencies. So it's kind of like going through your daily life with, with a handicap, with kind of extra, weight around your ankles, not feeling great, but not knowing why, not knowing that at least part of that might be because of certain vitamin deficiencies. So again, there can be a number of reasons. It can be anything from the food that one is eating, the food, where that food was grown, if it's plant-based, to issues with gut health and absorption of said vitamins and minerals.
Gotcha. Okay. So a lot of questions here because a lot of people take vitamins trying to solve for deficiencies, right? They just kind of, oh, I should take vitamin D, I should take some magnesium. Just curious, like, because a lot of patients before they come to the practice, this is their first kind of experience with more in-depth blood testing.
Mm-hmm.
How often are patients deficient in a vitamin they're still taking?
So one thing I do want to clarify is that we have vitamins and we have minerals.
Okay.
And so I think what we're talking about here is kind of both.
Yeah.
And we, as a general statement, kind of standard American diet, we tend to be more deficient in minerals than we are in vitamins, with some exceptions. Like I think we're going to dive a little bit deeper into things like vitamin D and some of the B vitamins. But in general, Americans as a whole tend to lack minerals more than vitamins, and largely that's because we don't eat enough plants, and plants are really rich in minerals. So some minerals people are familiar with, things like magnesium and calcium, and then there's some of the lesser known ones, maybe like selenium, chromium, things like that, which we also really need. So I just wanted to make that clarification. But I think your question was, how often is somebody kind of already supplementing with vitamins and or minerals, but they're still deficient? Is that what you're asking?
Pretty much.
I mean, just clinically, I would say fairly often. I see a lot of people taking multivitamins, and I think there's pros and cons, maybe, or it's better to say, sometimes people are using a multivitamin maybe not in the best way, is maybe a clearer way to say it. So I'm not in general like a huge fan of a multivitamin as a way to kind of like just take care of everything, right? I think that if what I usually tell people is if you are in a place in your life when you don't know how or you are unable to eat a well-balanced, whole foods based diet, right? And so you're either knowingly or not knowingly kind of malnourished, just not eating enough plants, just not eating a variety, etc., then a multivitamin might be the right thing for you. Or like maybe you're a parent and your child goes off to college and they're just not eating great. Like the food in the dining hall isn't good, or they're just like not really eating the way they did when they were at home. Maybe that's a good time to take a multivitamin. But what I really like about our testing and our ability to test is that we can get really specific in where are the deficiencies? Is it a magnesium deficiency? Is it a vitamin D deficiency? Is it an iron deficiency? And then target based on that. So it really is really individualized. Obviously, the best thing is food as medicine and to get as much as we can through our food. But unless we're testing, we don't really know what somebody's deficiencies are.
Okay, let's talk a little bit about getting vitamins and minerals through our food, because can you talk more about kind of what's happened to nutrients in the soil and food over time? Because that's a problem, right? I mean, we're not able to get the things we need through our food anymore. How much of that is true? How much of that is not?
Yeah. I mean, I think I'm not a farmer. Like, agriculture is not my area of expertise, but I think we all have some level of understanding that the way that our food is grown is different than it was 100 years ago. And, even the fact that food is shipped across the country or across the world, and we just eat we no longer eat locally, and we don't really eat seasonally either. And so we're all accustomed to getting an avocado any time of the year. Now, avocados are not native to Maine or anywhere around here, and certainly not in winter. So, there's just a level of that kind of like, you want what you want, you can get it anytime, and you can walk into any supermarket and you can get it. But I think that there are some things that have been lost with that. So I'm kind of digressing a little bit, but I think that there's chemicals that are used now with food production that are impacting everything, including our health, and in some ways like depleting these food sources from the nutrients that, if food was grown the way it was 100, 200 years ago, it would not be an issue. But things have just shifted to such an extent that we're not really getting that richness like we did.
Gotcha. All right. So let me ask that a different way. So, would it be possible to be 100% optimal with your health by just eating good food,
I see what you're saying.
or do you have to take supplements if you want to be as healthy as possible?
No, I think that if everybody's makeup is different, so it's hard to make a general statement. But no, I think it is possible to get everything you need through your food. Now, again, vitamin D, so if somebody were to eat the way the Norwegians eat or used to eat, where you're eating like fatty fish twice a day, you probably are going to get, vitamin D and great omega-3 fatty acids through your food. But most Americans aren't eating that way. And you're not going to find vitamin D in other food sources. I don't count like fortified milk as really an option. But for the most part, if somebody were really conscientious and had a super balanced, well-rounded, lots of variety, lots of plants, lots of fiber, yes, they could get what they need through food.
Cool. Okay. So is it possible that two of like the exact same physical person, so same gender, same weight, same age, can eat the exact same diet and have different vitamin levels and mineral levels?
Yeah, absolutely. Because your gut microbiome is different. You can be the same sex, same height, same weight, but your gut microbiome is different. So the way that you actually absorb, break down, utilize your food and therefore your nutrients is going to be different. And your everything, your level of like where your nervous system is. Well, your nervous system is going to need B vitamins. Like if you're really stressed out, then you're going to be kind of soaking up all of that B12 and you're going to potentially be at more risk of being deficient. Somebody who's not living with kind of a certain level of chronic stress, then they're not going to be as at risk for a vitamin B12 deficiency.
Okay. So that kind of leads me right into my next question, which is when someone has vitamin deficiencies, how much of treating it is giving them a supplement where they're deficient, and how much of it is treating the absorption in their gut health and their gut's ability to absorb and use, nutrients?
Yeah. Yep. I mean, both. I'm just a real big fan of doing things concurrently. So treating the gut, treating the nervous system at the same time, giving them the minerals, the vitamins that they need so they can start feeling better now, like while we do kind of what takes longer, the longer range work of like restoring the gut microbiome and gut health.
Gotcha. Okay. So what about all the people who've like gotten the online testing? Like I think Function Health is probably one of the big one. I know there's a lot of them now once they came out, and they, see where they're deficient. Now they're just taking a bunch of like supplements based on where they're deficient. Are those people gonna run into problems because they actually have a gut issue where they're not absorbing it properly?
Potentially. I mean, there's so many layers to this medicine, right? I mean, we talk about root cause medicine and kind of digging deeper, and it's not. You can kind of keep going, right? So one layer deeper than conventional medicine would be doing that level of micronutrient testing, which is fabulous. That's great. But then the next level is, well, why? Why are you deficient? And then, getting into gut health, getting into whatever is going on, like with an autoimmune condition or hormonally or nervous system or whatever it is. And you can kind of keep going. And that's where it's individualized, I think. That's where it's like, what is this individual's bandwidth? What are their priorities? Like at what pace do you go? Some people like want to dive in. They want to do all of it right now. And most people are kind of like, let's just kind of bite off a little bit at a time. So somebody who does that testing and then takes a bunch of supplements, there's also the question of, well, how much do you take, right, of said mineral or vitamin? They will probably feel better, which is great. But as I think you're pointing out, we're not really answering that underlying question, which is why are they not absorbing it, or why are they still deficient in iron, right? Like they can supplement with iron and their energy can be better, but why that deficiency in the first place?
Mm-hmm. Okay, so deficiencies, as we know now, can be a result of poor absorption in the gut. What about genes? Like you've heard a lot of talk about like methylation.
Mm-hmm.
Can you talk a little bit about that? Like what is methylation, and how does that play a role in, one's ability to absorb the nutrients they need?
So the one test that a lot of people have heard of is the MTHFR genetic mutation. That's kind of one of the most well-known SNPs or genetic mutations, and there's a lot of other ones that can be tested for, but that's kind of one of the primary methylation variants. So what it is it's like it's genetic. So if you have a genetic mutation or a genetic variant, that means that the way that you basically process B vitamins, for example, is going to be different. That when you take in B vitamins through your diet, through a supplement, your body has a harder time methylating. And so what methylating is, or the methylation process, is basically a process where those B vitamins can kind of be converted and actually utilized. So if there's a handicap there and the body is not able to methylate easily, then you could take all the B12, looking at the highest quality B complex in the world, but your body kind of doesn't know how to use it, or doesn't use it as well as somebody who doesn't have that genetic variant. And so you see things like elevated levels of homocysteine, which is an inflammatory marker. You see deficiency of glutathione, which is like a really potent antioxidant and kind of helps with detox pathways and inflammation in general. So those things are going to be kind of compromised when somebody has that variant. So one kind of, I guess you could call it a biohack, is like when you take a B vitamin, you take a methylated version, or if you take any vitamins, you take the methylated version. So they're already in a form that your body can utilize more easily.
Okay, gotcha. Because there's a lot of hype around methylation. And
Yep.
A lot of it was Gary Brecka.
A lot of it was Gary Brecka, and it even impacts estrogen metabolism as well. So it's but a lot of it was Gary Brecka. I agree.
Gotcha. Okay. So can we talk a little bit just about like conventional, like your primary care's approach to treating vitamin deficiencies versus a functional medical approach to treating vitamin, nutrient, mineral deficiencies?
Yeah. So, I mean, I don't want to put all primary care providers in one basket, because I know that just like all of us, all providers, is a huge range. And, over the years, I have known primary care providers who do say somewhat routinely test for vitamin D, which is great. That, and maybe B12. But that said, nutrition in general is not taught in medical school, in conventional medical school. And it's just not part of the training. It's not usually part of kind of their toolbox. So just to have that as a background, it's kind of, I guess, can at least traditionally not even on their radar to kind of test for deficiencies. Unless it's something, just for standard kind of routine care, that's just not something that they're going to really think about. Now, there's some exceptions, like if, they suspect somebody's anemic, they're going to test your iron level, and maybe your ferritin, hopefully, which is your body's like reserves or storage of iron. But so first of all, it's just not really on their radar. It's not really tested that much. And maybe because in functional medicine, we do have more training, more awareness of nutrition in general, that encompasses minerals and vitamins, and kind of checking for those micronutrient levels. Does that make sense?
Yeah, gotcha. And what about the ranges though? Because you go to your
okay, and then there's that. So this is kind of a classic normal versus optimal difference. So vitamin D is a good example. There's a lot of kind of fear, I would say, in conventional medical thought about vitamin D toxicity. And part of that is that vitamin D is a fat soluble vitamin. So it can technically kind of be stored in the fat. We don't, unlike the B vitamins, which are water soluble, we kind of pee out, water soluble vitamins. You don't really have to worry about like toxic levels. But vitamins A, K, E, D, those are fat soluble. So there's this kind of fear around someone taking too much vitamin D3. And they will say that a normal level is like 23. And this is, I think, nanograms per milliliter are the units that I'm referring to. So for me and most of us in functional medicine, if somebody comes in with a vitamin D level, this is serum or blood that we're talking about, at 22, 23, that's deficient. Maybe not technically, but it's certainly like suboptimal. So that person that's impacting everything from thyroid to neurotransmitters to bone mineral density, to immune function, right? Our goal usually with a serum level of vitamin D is like at least 60, anywhere from like 60 to 80. Some other practitioners will say even higher. You don't really have to start worrying about toxic levels until you get close to 150 nanograms per milliliter. And in my clinical experience, that's really hard. That's really hard for someone to get to that level. So that's one kind of good example, I think, of a difference between normal versus optimal, in terms of levels. Yeah.
Gotcha. Makes sense. Okay, so diving into some of the show note questions here. Can stress, trauma, chronic illness essentially maybe burn through nutrients faster or like make you more prone to deficiencies? And if so, which ones would be most affected?
Yes. Primarily, the first ones that come to mind would be like vitamin B12, and then mineral-wise, magnesium. So both B12 and magnesium are like fuel for the nervous system and the adrenal system. And so when you've experienced trauma, when you've experienced stress of any sort, the nervous system, the adrenal system, that's how they're kind of surviving, right? Like that's what they're running on. But yes, I guess you could say burning through that vitamin, that mineral, more than a person who's in a more relaxed state would. So you're much more prone to become deficient. And you're getting those through food, maybe through supplementing. But it's a pretty common picture, unfortunately.
Gotcha. Okay. So how do nutrients and minerals, vitamin deficiencies play a role in your mood, in your energy, in your motivation? And if so, like what are the most common offenders when it comes to the vitamins that are really important in just the way you feel?
I mean, probably all of them. The ones that we kind of look at first would be ones that I've already talked about, but vitamin D definitely in terms of mood regulation. It's kind of classic, like part of the reason, in the fall and this time of year, why I'm really aiming for all of my patients for their serum levels of vitamin D to be as close to 60 or higher is because of things like seasonal affective disorder and the fact that the days are shorter. And a lot of people are really affected by the lack of light. And so having optimal levels of vitamin D is one way to help alleviate that to some extent. Yeah, I mean, if you're stressed, if you're tired, kind of a B12, a B complex is gonna be big. If you have muscular tension, if you're stressed, then magnesium is gonna be really important. And if you're tired, we're largely looking at like iron, and sometimes it can kind of bleed into more of like a depression, kind of that fatigue, depression, malaise. Sometimes it can be a little hard to tease those apart. So those are all, again, it's like what I said in the beginning. It's like walking around with these handicaps that are essentially kind of low-hanging fruit in terms of fixing them. Again, we want to dig deeper, like, we want to deal with the trauma, we want to deal with whatever the underlying issue is, but it's pretty easy to replenish those micronutrient deficiencies. So even though it's probably a complex situation, that's one thing that you can do quickly. And every day people say, they come in for their vitamin D injections and they're like, I felt a difference immediately. I had a woman yesterday when she came to us, her vitamin D level was under 10. I think it was like 9.71. And
Okay.
again, our goal is 60. And so that is technically deficient. That's not just suboptimal. And so I had her come in once a week for an injection, and she would leave every time just feeling so much better. And, we were only in 2.5 months, we were only able to get her serum levels up to 23. But again, it's better. But we have a little bit more work to do there.
Just curious, what did that patient know anecdotally as far as like the way she felt after just like more
energy? She just felt better. She just felt like she wasn't dragging, and just like her, like mood, her mood just lifted.
Gotcha. It's a good example. So, hey guys, we really appreciate if you're joining us live right now. We got about 6 more minutes left in this subject. So if you have any questions and you're joining us live, feel free to drop them in the comments, and we'll see if we can get to them with Dr. Rose, or just give us a thumbs up. We'd love to know you're there. If you are interested in becoming a patient, you can go to medmatrixusa.com and apply there. Okay, so back into the show. How do vitamins, nutrients affect sex hormones?
That's a good question. I mean, I referred to it briefly earlier in terms of estrogen metabolism. So say somebody has a methylation mutation, they're taking B vitamins, but they're not methylating them properly. That's kind of inadvertently or indirectly going to kind of affect estrogen metabolism. If this is an interesting one, we actually need cholesterol to make sex hormones. And so, like, for example, if somebody's taking really high doses of a statin medication and they don't really have that much cholesterol, like that's going to affect their sex hormones. But from a nutrient perspective, like we need healthy fats, and that's going to kind of provide the building block for sex hormones.
Okay, so can you explain more how like the vitamins actually affect? Like let's use vitamin D as an example.
So say
that's one where everyone's like vitamin D, like, but how does vitamin D actually affect the way you feel? Can you kind of break down the
in
science,
terms of sex, like the sex hormones?
Yeah, sex hormone. Just like why is vitamin D so important in the way you feel?
Well, because it affects your it's like neurotransmitter balance. It has a role in terms of neurotransmitter metabolism, essentially. And it affects your like inflammation. And so a lot of this, I guess I would say, is a little bit, like in my mind at least, a little indirect, right? Like you need these building blocks, you need sufficient vitamin D in order to have lower levels of inflammation, and in order to have optimal neurotransmitter metabolism and regulation. So it's like part of the broader picture of a healthy neurotransmitter response, which is going to affect your mood. I know that might not be the most satisfying answer, but it's like part of a bigger puzzle.
Gotcha. Okay, makes sense. Let's see here. Just wrapping up the questions on the notes here. So why are like nutrient? I guess to give context for this next question is like, how many patients, when they come in after doing a whole bunch of testing and they sit down with you for a full hour, what % of those new patients are deficient in some vitamin or nutrient or mineral?
90%.
Wow. Okay.
Pretty high.
Why do you think it's so high?
So it could be anything from, well, vitamin D. It could partly be because of where we live, and that we're not really eating, again, like we really don't eat fatty fish, which would be helpful. But largely it's kind of where we live. And then, so part of it's how we eat. Again, circling back to kind of like the foods that we eat, how those foods are grown, and gut health. And then there's things like iron, right? Does somebody have a gastric bleed that's undiagnosed? Is it a menstruating woman who has really heavy periods and she's losing iron every month? Is it a person who has a vegan diet and they haven't been kind of addressing, making sure to get enough iron supplementation? So everybody's a little bit different, but it's super common. And again, it's that also a difference between like optimal, right? So somebody comes in with a vitamin D of 26, I'm going to treat that. In a conventional medical practice, they'd say that you're fine. So in my mind, they're deficient. Not every provider, outside of functional medicine, not every provider would agree.
Gotcha. Okay. And then to bring us home with this, this segment, can you kind of explain a treatment plan or a patient case study other than the one you brought up earlier, regarding like nutrient deficiencies?
Yeah, I mean, let's see. Well, this is a pretty common scenario. I do have a fair amount of people who, we go through all the blood work and we go through like the whole health history, and there's like a lot of things that we can do as we've kind of said before, for a lot of people, it works to just kind of do one step at a time. So sometimes I'll just kind of do an outline with somebody of these are in general a lot of the things that we can do, including, your ferritin is low, your B12 is low, and your vitamin D is low. And sometimes what people say is, well, I think I just want to start with that. Like that's kind of, I want to take off like a small bite at first. So I will give you a specific example. I have a patient. He's gosh, I don't know if he's 30. He's kind of late. I think he's late 20s. And he kind of fit that picture where there were like a lot of different things that we could have done. And his like stress level was pretty high. I think even like his cholesterol was a little bit higher than optimal, but he was very deficient in iron, ferritin, all of them, all the standard ones that we test. I think his magnesium level was fine, but B12 was low and D was low. And so he chose just to focus on that, to kind of eat, to kind of bump up, animal protein, which would help with the B vitamins, take a B12, a sublingual B12. I had him come in for some of those weekly D injections for 6 weeks and then switched him to oral vitamin D3. I always add in vitamin K with D3. The reasoning for that is that D3 is going to increase your absorption of calcium. You want that calcium to go to the bones, not to the arteries, and that's where vitamin K can help. So I switched him after the injections. We went to 10,000 IUs per day of D3 with K. And then an iron, like a chelated iron that's non-constipating and would boost iron and ferritin levels. So he did that for 3 months. And then I retested those levels and saw him, and the levels had all improved. It was the same thing. His vitamin D went from, he wasn't as low as the other patient. He was probably like, I think he was around 20, and his vitamin D went to 40. Great. Still not at 60, but better. And, but most importantly, he just felt so much better. And so it was like, again, low hanging fruit, like a few adjustments, didn't really take a lot, but, it was a great first step.
Great example. Okay, 2 more questions popped in my head. So one's about milk, because milk is like infamously good for your bones, right? And high in all sorts of good vitamins you need, right? I honestly don't even know I think vitamin which vitamin is milk famous for? C?
Calcium,
calcium.
calcium and D and
Yeah, calcium and D. So like, is that true? Like, should you drink milk for strong bones?
I mean, that was one of the best marketing ads in the history of advertising, right? I mean, the fact that like people still say that is amazing. Like whatever lobbyists they had or marketing people did a good job. They I mean, there's calcium in milk and they fortify it with vitamin D. There's just a lot of reasons why. So it's partly generational. Like I have patients in their 70s who still drink a glass of milk with every meal. And I don't think milk is bad, but I think that I don't like that quantity of milk. It's like dairy is often really inflammatory for people. It can contribute to things like postnasal drip and kind of a excess mucus and phlegm, just inflammation like overall. It's just not my favorite way to get calcium or D. You can get calcium through leafy green vegetables. You can get calcium through almonds, like you know, through legumes or beans. Like you really don't need to have milk to get calcium. You certainly don't need it to get vitamin D.
Okay, so what's the difference between getting a vitamin or nutrient through a supplement or getting it through a food? Like, is it really better to like try to fix your diet, get all the nutrients, or should you just take supplements because like it's the same thing?
I think it's some of both, right? I mean, we kind of talked about this. Like, I think, yeah, in an ideal world, if you could really, it's almost like your full-time job was like optimizing how you eat, but that also means optimizing your gut health, and kind of knowing what your baseline is and then optimizing it from there. And knowing exactly where your food comes from, how it's grown. Like, yeah, I mean, you do like, yeah, we should all kind of work towards that. Just in all honesty, it's just not super realistic, I think, for most of us to be able to get everything we need through our food, given just the way that our culture and our lifestyles are right now. So I think it's good to have like a blend. Supplement when you need to and have that be like targeted supplements, in addition to, eating a balanced diet rich in vitamins and minerals.
Gotcha. Okay. Sounds good. All right, and I'm gonna play devil for this last question.
Okay.
I'm gonna play devil's advocate. I'm gonna come at you a little bit. So why should someone actually spend, a good chunk of money, get all this blood testing done, sit down with a functional doctor like you for an hour when they could just go take magnesium, vitamin D, calcium, B12, methylated B12 supplements? Like why go through all this testing and effort and money? Obviously there's other things they can do, but as far as vitamin deficiencies, like why bother?
Not everybody's deficient, and you don't know unless you do the testing and unless you talk to somebody who's really seasoned in this. You don't know if you're deficient, and you don't necessarily know that difference between like deficient versus optimal. And it's the conversation is held within the context of your health history, what your energy levels are, what your sleep is like, what your stress level is like, what your digestion is like. So it's not like in isolation. So we don't all need magnesium necessarily. Probably most of us do, but until you really kind of test it, you don't really know what your baseline is. And even like B12, like if somebody's like, I rarely hear this, but I have as much energy as I want. I wake up in the morning and I feel amazing. And their vitamin B12 on the blood test is low. They might not need B12. Like they feel great. They're not stressed. Their energy is fabulous. So you have to match the whole health picture and the symptom picture with the deficiencies. So that's where we come into play. And we talk about, well, what are you eating? And, so it's part of that broader conversation.
Gotcha. Cool. All right, guys. Well, thank you for all who joined us live. We're about to transition into the next segment. If you are watching a recording of this and you want to become a patient, you can apply by going to medmatrixusa.com and clicking get started. And yeah, let's move on into the next segment, which is hormone deficiencies. So why are hormone, and first with the new segment, just got to say it, nothing you hear today is medical advice. It's really just education. That's all. So let's get into it. All right. So, Dr. Rose, for the people who are just joining us, for the people who are watching the recording, can you tell us a little bit about kind of your experience in hormone imbalances and hormones in general?
Yeah. I mean, it's just a huge part for all of us, kind of really no matter what sex, what stage of life. I think we usually start to have that conversation with both women and men kind of, once they're in their 30s, 40s, and definitely 50s. And so hormones in general is just part of it should be part of the conversation really with almost any visit. You hear about perimenopause and menopause, and then in men there's kind of andropause when testosterone starts to drop. So there's a lot, I think, in the media and social media right now about hormonal health. It can be tricky because these hormones are in the blood, and again, they affect everything. They can affect your mood. They can affect your sleep. They can affect your libido. They can affect even your physical strength. And so it can be hard to say, well, is it my hormones? I don't know. It's not always so clear cut. So that's kind of where we dive deep and try to kind of suss that out for each individual.
Gotcha. All right. So let's just kind of like, for people who aren't aware, how do hormones play a role in the way we feel in our aging and our strength, just everything? Because hormones pretty much regulate and control the way we feel, right?
Yeah. So, we do talk about that triangle where there's, sometimes when we say hormones, I think by default, we are talking about the sex hormones. So the hormones like estrogen, progesterone, and testosterone, which are secreted by the ovaries and the testes. But insulin is a hormone, right? There's a lot of other hormones. The ones that we usually talk about being kind of intimately connected would be the adrenal hormones. So people have heard of cortisol. Another adrenal hormone is DHEA, and then there's thyroid. And so these are all really intimately related and impact each other. So yes, hormones, hormonal fluctuations, hormonal imbalance, those are going to affect everything. Mood, just how you feel, for sure.
Okay, gotcha. So, when do people normally start experiencing hormone deficiencies? Like average person, right?
Yeah. So, what we find with, I'll just use perimenopause as an example, is that perimenopause is going to be kind of when your sex hormones start to fluctuate, right? So normally before perimenopause in a woman who's cycling, every month there's like a certain rhythm. I won't go into the like really nerdy details, but basically there's there's certain hormones that have like FSH has a spike at a certain time, and progesterone, we don't really have any of the first 2 weeks, but we do have progesterone the second 2 weeks of the cycle. And it's very regular. And then starting even as early as age 35, those can start to fluctuate. And it's not necessarily a deficiency at that point. It's just more of a kind of erratic, I guess. And it can be different for every woman. But it can be a drop. It can be like a deficiency. There's not quite as much progesterone being produced, not quite as much estrogen. But again, for 10, 15 years, there's just kind of this up and down. Every month might be a little bit different. What's tricky is we obviously do really like to test for hormones, but clinically, we're not necessarily going to see a deficiency in that perimenopausal window. We're not going to necessarily see that a woman's ovaries are not putting out enough progesterone or estrogen because it's just a snapshot. And it's the fluctuations that are the issue, not necessarily like the overall amount of hormone that's the problem. It's really not until a woman is menopausal, postmenopausal, which is technically you do not have a cycle for 12 months is when you're technically in menopause, that she's kind of really not making any anymore. And that is obvious on blood work. Like that, I can look at the blood work without meeting the woman, and I can just know, I don't even need to know her age. I can just look at the numbers and I can tell she's menopausal. because there's just not much there. So that's a huge range that some women are going to start experiencing that at age 35, and other women, I mean, I have some patients who don't, really start to feel anything. Their cycles don't change until they're like 54. It's like a 20-year span, right? So, and then men, I mean, testosterone, there's different reasons for kind of a drop in testosterone. There's, age-related testosterone usually drop is usually we see that starting mid 40s, I would say, is when, at least on the blood work, when you start to see it. There's plenty of men that have kind of suboptimal levels of testosterone earlier, but when it's like age-related, I would say mid 40s.
Okay, gotcha. Do you feel like balancing, let's talk about sex hormones specifically. Do you feel like balancing sex hormones is the greatest lever you can pull against anti-aging?
Well, there's a question. Yeah, it might be. If I had to pick one lever, yeah. I mean, it can be such a shock to the system to have those fluctuations, to have those drops, that and it can be such a safe therapeutic tool when done right and when kind of tailored to that individual's needs, that it, I mean, you've heard me say this, like, people's lives are changed. Not everybody, but a number. People are just, they're not sleeping, they have brain fog, they're irritable. So right there, that's going to affect every aspect of life, right? That's going to affect family life, work life, energy, your intimate relationship with your partner, your relationship with yourself. And then there's like weight gain that goes along with it. And so pretty soon it's like, you just, as people say, like, I just don't feel like myself. And it's confusing because it just feels like it came out of nowhere. So, yes, I think when you can kind of like, and all of those things are going to age you essentially, right? Chronic sleep deprivation right there, that's going to age you. So I think when done right, yeah, I think it is probably one of the strongest tools in longevity medicine.
Okay, gotcha. So I mean, we hear all the time, people go to their normal doctors and they're told, the patients go to the doctor and they say, hey, I want to test my sex hormones. And then they're told, oh, we don't do that, or, oh, it doesn't matter, or blood testing for sex hormones is irrelevant. What is your kind of take on that?
So I think this is still current, like the American Association of Gynecologists, their general recommendation is like it's not part of standard of care to test hormone levels. And we do it for a couple of reasons. One is to get a baseline. And the other, to get a baseline, and to, because we get really specific on estradiol, which is the strongest form of estrogen. There's like there's a whole number of biomarkers around testosterone, not just total testosterone and progesterone. And, it's a very complete list. So we get really, like, at first glance, we get like a really comprehensive baseline picture. So good to have for anybody. And then if we do start some kind of bioidentical hormone plan, it can help us monitor moving forward. Now, most important, where I guess I do agree with kind of that more conventional medicine model of not testing, somebody's symptoms and their response to the hormone replacement therapy, that's more important to me than chasing lab values. I like both. I find that putting them together is like the most valuable, but I do agree that, if somebody, I guess I'll just use progesterone as an example. If somebody tells me that, now that they're taking their oral progesterone before bed, they're they're now not waking up between 2 a.m. every morning like they used to. and they feel better when they wake up and they feel better throughout the day. But their progesterone levels, on blood work, their progesterone just went up a little bit. Like it changed, but it wasn't like drastic. That's great. I don't need to pump them. I don't need to give them a much higher dose of progesterone. They're already responding really well. So that's kind of how I use the blood work. I do think it's really helpful. And I also don't really understand the mentality of like, I don't see why not. Like if somebody goes to their physician and they ask for it, it's basically dictated by the insurance. Like unless there's like a reason why the insurance to cover that testing, it's not going to be ordered. But being free of those restrictions, like why not? If somebody's curious and you know how to interpret them, I don't see what the harm is.
Okay, gotcha. So what about, let's talk about the gut connection and hormones. I mean, all the time in kind of like social media, especially around health, you hear, oh, gut health, right? Gut health is so important. But how is gut health connected to your sex hormones?
Yeah, so this I find really fascinating. There's something called the estrobolome. It's not the estrobiome, it's the estrobolome. And this is like a subsection of the microbiome. So it's gut microbes, which are responsible for basically what we say conjugating or kind of metabolizing, breaking down estrogen. So ideally, estrogen, like again, ovaries produce estrogen, circulates through the whole, all the estrogen receptors. The body kind of gets what it needs. And then the liver and that gut microbiome kind of bind that estrogen up. And then you poop out the rest. You don't need it. If somebody's estrobolome or that part of the gut microbiome is out of balance, then that doesn't happen. That process doesn't happen. And the estrogen gets recirculated a second time, a third time. It kind of stays in the system longer than it should. And therefore, estrogen locks into estrogen receptors more often than it should. And so you start to get, it's like more exposure than what is optimal, right? More estrogen exposure. So then potentially a woman is going to have what we call estrogen dominant symptoms. And that can be for a woman who's cycling, PMS. And that can either be like emotional signs and symptoms of the emotional premenstrual syndrome, or it could be physical. It could be really tender breasts. It could be really bad cramping. It could be really heavy periods. And so it's that, again, that's like, you would not think that was like a gut issue, right? But essentially it is.
Interesting. That's so interesting. So how do you fix that? Just curious. Like when that's happening, what's your approach to fix that?
So there's certain supplements that again, you know me, I like to test. So I like to test to see what's going on at that gut level. And there's certain kind of biomarkers, like something called beta glucuronidase is one enzyme that we can test for, which can kind of tell us what's happening with that estrogen metabolism. And there's certain supplements that we can take, actually kind of bumping up one's fiber intake, whether that's dietary, like through your food, even taking an insoluble fiber, that's going to help. And for some women, while you're doing that, while you're kind of like optimizing that part of the gut microbiome, bumping up progesterone, which estrogen and progesterone kind of balance each other out. So sometimes taking oral progesterone, especially during that second 2 weeks, the second 2 weeks of the cycle, then the luteal phase, that can really alleviate symptoms. So yes, you have to figure out the estrogen metabolism piece, but you can also kind of just feel better and find more balance when you're optimizing progesterone at the same time.
Okay. So let's keep going with this subject. How do microtoxins, so like things like mold and other toxins, things like arsenic, play a role in affecting your sex hormones?
Well, those are going to affect the liver, and the liver's kind of detoxification pathways. And so if those are compromised and it's kind of, you're not processing anything optimally, whether it's mycotoxins that you've, mold, spores that you've been exposed to, heavy metals that you've been exposed to through your occupation or other sources, then that's already compromised. It's going to make it that much harder to kind of metabolize conjugate estrogen as well.
Okay, gotcha.
Yeah.
So can you break that down for people who might not know what that means?
So we all kind of know in general that the liver is like a really important organ, and it's important for a lot of reasons. But one big reason is that it's our primary detoxification organ. So everything that we put into our bodies, food, medications, supplements, and then unintentional things, maybe like mycotoxins or heavy metals, that all has to go through the liver. And so the liver has to kind of process all of those, break that down, again, get it into the digestive tract so that it can be eliminated. If the liver has a level of inflammation, if it's kind of overtaxed, right? So there's a lot of medications, there's a lot of alcohol use, there's even sometimes like a little fatty liver is going to partially impair detoxification. It's like that load. If that toxic load is just kind of gets higher and higher, things aren't going to process effectively as efficiently. Now, I do have to make a point that genetically we have differences too. Some people are like fast processors and some people are slow processors. So it's why some people handle alcohol differently than other people. Why some people have a certain response to caffeine, like they feel caffeine much more strongly than somebody else. A lot of that is just genetic. It's not that you're doing anything right or wrong. It's just kind of how you were designed. But you factor all of that in, and that's partially going to impact also how you metabolize the sex hormones.
Okay, so if you're someone who's more affected, this is kind of off topic, but
That's
so
okay.
if you're someone who's more affected by caffeine, so like you're more sensitive to coffee,
You're probably you're slow because it
okay.
stays in your system longer.
Okay, so are you more prone or less prone to being more affected by alcohol, or are they not connected?
You're probably more. You'll be more sensitive, more affected.
Okay, gotcha. So if you're more sensitive to coffee, then you'd be more sensitive.
Usually, yeah. Well,
okay.
I think so. Yeah.
Yeah. Okay, because because it stays in you're not as efficient of a detoxer, if you will.
Exactly. Yeah.
Okay. Cool. All right. Fun little fact for everyone.
Yeah.
All right. So let's talk about this saying that everyone knows: stress kills. Like, scientifically, how does stress actually kill you? I think in relation to talking about cortisol. Yeah, tell me more.
So people think of cortisol as like the stress hormone. So it is produced in the adrenal glands, and it is produced. Well, I'll just back up a little bit. The normal, what we call diurnal rhythm of cortisol, like in a healthy individual, is that your cortisol has a spike in the morning when you wake up, and then it kind of drops between 8 a.m. and noon, and then it continues to drop between noon and midnight. So in an ideal world, your cortisol is really at its lowest while you're sleeping, which should be at night, and at its highest in the morning. And what happens is usually early in life, I'll say this, this has impacts, trauma, stress has impacts for any age, but if somebody is living in a home or living with a level of trauma where they just don't feel safe, like for years and years, that cortisol is not going to drop, right? So they're going to be in this like hypervigilant state most of the time. And that over time, the adrenals can't put that out anymore, right? So that's kind of like this person's default is to have elevated cortisol all the time. They're in fight or flight mode. They're like, they're not coming down. After decades of this, the adrenals aren't able to really continue to have that same output. And so you start to get dysregulation where they're not getting that morning spike anymore. And it's high at night, but it's low in the morning, and it's kind of all over. And then the third stage of what we call like adrenal fatigue is there's really not much cortisol at all. The adrenals are kind of shot. It's like an empty gas tank. So, and that's, that level of fatigue is pretty significant. And there's, you're really just not able to, really, really low cortisol, you're like barely functioning. So I guess that would be kind of your definition of stress kills, but it's a chronic thing, and it's just running on empty is one way to put it. Did that answer the question?
It did. Yeah. And I just wanted to thank everyone who's live with us right now. If you have any questions, we're kind of coming to an end on the hormone deficiency segment. So feel free to drop some comments. And if you are interested in becoming a patient, you can apply at medmatrixusa.com. So kind of bringing us into the final stretch here. What is sex hormone binding globulin?
Globulin.
And why is it important? Because I think this is one that's pretty overlooked.
Yeah, it definitely is. Yeah. So it's a part of our standard panel that I really appreciate that we have. So again, usually if you go to a provider and they test your testosterone, this is man or women, although usually it's men who are asking, you're going to get a total testosterone level. Sex hormone binding globulin is a protein. It's globulin. It's a type of globulin, which is a type of protein. And the way that I talk about it is that it's floating around in the blood. All of this is in the blood. Remember, all the hormones are in the bloods. So you've got this protein, and then you've got your testosterone molecules, and they're all floating around together. When a globulin molecule connects to a testosterone molecule, it renders it inactive. That testosterone molecule can no longer lock into a receptor. It cannot kind of do its job. So a high level of sex hormone binding globulin is going to basically detract from total testosterone. So we also include tests like free testosterone and bioavailable testosterone, which take that into account. So those are actually more telling than the total, because it's kind of the calculation after taking the sex hormone binding globulin number into account. So here's an example. A man has a level of 450 on his total testosterone. And you're like, in conventional medicine, you're like, you're fine. But his sex hormone binding globulin is over 100. Now we really want that number to be for men, I think we want it to be between like 20 and 40 for sex hormone binding globulin. So say for whatever reason, there's different theories of why that might be elevated, but say his sex hormone binding globulin is really high. Really, essentially, the bioavailable testosterone, what his body can actually tap into, is not even close to 400 or 450. It's probably closer to 200 or something. So this is a guy who's probably pretty tired, low libido, low motivation, maybe goes to the gym, but really has a hard time seeing results. Like the skeletal muscle mass development is not what he wants. So that's just an example of how sex hormone binding globulin plays a role. And if you're just testing total testosterone, you're really not going to have that full picture.
Okay. Gotcha. So pretty important to know, right? And I think on the initial panel. So what about, and then what about like bioavailable testosterone too?
Well, So what we see is we get all of that. We get total testosterone, we get sex hormone binding globulin, we get free testosterone, and then we get bioavailable. And so, yes, I'm looking at total, but I'm more interested probably in the free and the bioavailable, because again, that's what his body can actually utilize.
Okay, gotcha. Let's talk about two more kind of more specific hormones. Let's talk about DHEA. What is DHEA
Okay.
and why is it also very important in just well-being?
Yeah, so people kind of in the longevity medicine space talk about DHEA. Um, it is also made by the adrenal glands. It's kind of like there's all these pathways, right, with sex hormone, kind of how you end up with the final metabolites of sex hormones. DHEA is like one step along the way. I think of it sometimes as a precursor hormone. So it's made by the adrenal glands and then it gets converted to but testosterone and then estrogen. So if you're starting your raw ingredient, your DHEA is low, it's going to be harder for you to have optimal levels of estrogen and testosterone. It can be one reason why potentially you're suboptimal with those hormones because that starting raw ingredient isn't as optimal or as high as we'd like it. DHEA does decrease. It's supposed to decrease with each decade of life. So a younger person inherently is going to have a higher level than an older person. So the goal for most of us as we get older is to maintain, a certain level of DHEA. And we specifically measure kind of a metabolite of DHEA. It's DHEA sulfate or DHEAS. That one's just like easier to measure in the blood. So, coming back to stress, again, this is made in the adrenal glands. Chronic stress is usually kind of the culprit, I would say, if somebody has suboptimal levels of DHEA. It's not that they had, a stressful week the week before they did the blood draw. This is like chronic stress, right? Like a history of trauma, history of, a really bad long-term bad relationship, whatever other types of stress and trauma the person has dealt with have taken a toll on the adrenal glands, and it's just not making that raw ingredient of DHEA anymore. So in addition to, the kind of more well-known types of hormone replacement therapy, sometimes we will prescribe DHEA to kind of support the adrenals, help with that raw ingredient, and then monitor that's helping to boost things like serum levels of testosterone and estrogen.
Okay, all right. So, um, why not just take a DHEA supplement as you get older?
You don't know what your level is. You might not be low. If it's not low, you don't need to supplement.
Mhm.
And you can't, it's just good to have that baseline before you then just randomly start supplementing. There's also different dosages, right? Like sometimes we just start with 5 milligrams and then we build up to 25. But unless we kind of know what the level is, what your goals are, it's like hard to tweak that. There's also some providers that you can get DHEA in kind of over-the-counter supplement form, or you can get that compounded through a compounding pharmacy. And there are some providers, and I have seen this with some people, that the person actually feels better. Like you actually just get better results when it's compounded through a pharmacy. That's more of kind of like a clinical anecdote that I've seen a couple times, and in conferences I have heard other providers say that. So again, that's going to need kind of professional expertise in figuring out the right dose and getting that prescription done correctly.
Gotcha. Okay, and then last specific hormone we're going to talk about is prolactin. What is prolactin?
Mhm.
And I think that's referred to as your like motivation hormone, right? Can't. Yeah.
Um,
Talk more about that.
I don't think of it like that. I'm it's I mean, I'm usually looking at it kind of as part of the overall like reproductive sex hormone picture. Um It definitely plays a role kind of when a woman's lactating. It's made by the anterior pituitary. And one reason why we test for it is that if it's really high, we need to rule out a pituitary tumor, benign or malignant, but pituitary tumors are not exceptionally rare. Like, they do happen. And so testing prolactin is kind of one easy way to just make sure that there's not any kind of tumor. But it can also, if the prolactin levels are off or if the pituitary is kind of not functioning as well, you may see like a woman might have irregular menses. She might have actually, I have had a couple of patients over the years. I had a woman who, had not just had a child, was not breastfeeding, and she started lactating. And that it was, and then down, after kind of all the workup, there was a pituitary tumor. So irregular, higher than desired levels of prolactin can be detected when somebody is dealing with infertility, again, menstrual irregularities, and low libido. All of that can kind of play a role. So maybe it's kind of when you, what did you say that you'd heard about it?
I forgot. I forgot where
you got it. I lost your audio.
Can you hear me?
No, I can hear you now. Yeah.
All right, I just switched to my computer.
Okay.
So, yeah, I was talking to another provider, but we
Okay.
I'll have to get back on that.
Okay.
Okay, so let's do one more question here. Let's see. Let's pick a good one. We got a lot of them that we didn't get through. We'll have to do another episode. Let's talk a little. Let's just do one little bit on hormone replacement therapy, because I know it's something we do a lot here at MedMatrix. Like, what's the difference between bioidentical hormone replacement therapy, something that we do a lot of, versus kind of like the synthetic hormone replacement therapy that most women would get by, they go to their OB, or just what you would normally experience.
So the quick answer to that is that bioidentical hormone replacement is they are molecularly identical to our own hormones, whereas synthetic are molecularly similar but not identical. And so, for example, like conjugated equine estrogen was the hormone, which is synthetic, was the hormone that was used in the kind of now famous Women's Health Initiative, which is what caused like the medical community to tell everybody to go off of HRT in 2002, just like overnight. So bioidentical hormones are generally considered safer because they kind of much more closely mimic our own hormones. The hormones that are in birth control are synthetic. The hormones that we prescribe are bioidentical. So that includes like oral progesterone. We almost exclusively use transdermal estrogen, which means like a cream or a patch, and that is also bioidentical. So it's really an issue of safety, and that most people prefer to put more natural substances in or on their bodies than synthetic. I will say this, like, if you go and you get an estradiol patch anywhere that is bioidentical. Like it's not like you can, a gynecologist can, or a primary care can prescribe an estradiol patch, and that is bioidentical. They're just not all. First of all, a lot of them are refusing to do it, and it's a skill in knowing how to prescribe it and knowing how and when and what level, because there's varying differences in dosage and concentration, etc. So it's like a whole, we call it like menopause medicine, and it's a whole another level of training. So it's not that like, you can't get it elsewhere. It's just that it's not, most people aren't really well trained in it and or aren't really willing to do it.
All right. Good answer. That was a good explanation. Thank you. So, all right, guys, that'll do it for today's segment on vitamin deficiencies and hormone deficiencies. We talked kind of about both men and women there. So yeah, if you're listening, you're live now with us and you're not yet a patient, you want to become a patient, you go to medmatrixusa.com and you can apply there to become a patient. Don't forget to like, share, subscribe to the channel if you want to hear more. We go live pretty much every Tuesdays, some Wednesdays, some Fridays around 4:30. If you like joining in, and that is everything. Doctor, is anything else you want to say?
No, it's great. Great topics.
Awesome. All right, everyone. Thank you so much for joining live. See you in the next one. Bye.